right, everyone, thank you for joining us today with ACEP Now. And thanks to Dr. Marianne Gausche-Hill, the president of American Board of Emergency Medicine, for joining me today. Dr. Gausche-Hill, ABEM isn't really your full-time job. Can you tell us what your day job is, so to speak?
Sure. I'm currently a practicing emergency physician at Harbor UCLA Medical Center in Torrance, and I work in both the pediatric ED and the adult ED as the medical director for the Los Angeles County Emergency Medical Services Agency here in LA County. So I oversee all of the pre-hospital care here in LA County. It's about 88 cities.
We talk about a little bit of the MCert process in our December issue of ACEP Now, and one of the things that's written in there is you say that the MCert is more of an assessment for learning rather than an assessment of learning. And for those of us that might not be academicians or specifically trained in sort of medical education, can you explain to me what you really meant by this?
Yeah, it's a great question. Assessment of learning tests, like medical knowledge, cognitive skills, things like that. And so the qualifying exam, which is part of our initial certification examinations, are an assessment of learning. Assessment for learning really integrates all your learning opportunities. In addition, through the process of taking MyEMCert, which is a more formative approach. In addition, one of the things that we provided is key advances. These key advanced synopses take, let's just say, clinical guidelines, recent randomized trials, or other, practice alerts, and synthesizes those into synopses. And also we have some short osmosis videos too. But what's great about the synopses is it takes that information and it really, we have a new advances panel, which includes, evidence-based medicine experts, where you synthesize it down so that you can get a large amount of information in a short period of time. In addition, the synopses also have additional resources.
We also ran an opinion article from a couple of ACEP members that are board certified that were arguing that maybe now's the time to do away with the oral boards component. And I was wondering, is ABEM actively considering that as an option for the initial certification, or is it something where the oral boards will continue to remain?
Well, right now we have a becoming certified or initial certified task force, and we're getting input from all the major emergency medicine organizations. And that includes also all of our currently board certified emergency physicians. So as an example, anyone who's listening to this or reading your article could go to our website and just Google Becoming Certified Task Force, and there's a link there that you can offer your opinion. So we're getting lots and lots of input, but plus we are sending a survey to literally every board certified emergency physician in the United States. So the idea is to get a lot of feedback, and so everything is on the table in terms of where we go from here, right? The task force, again, really wants everybody to participate as they can, because I think, the key thing is your opinion matters, and we take that all really seriously. So to answer your question, we aren't specifically looking at retiring it, but with that said, as I said before, everything is on the table as we really look at our initial certification process and try to decide, what are the best methods for us to evaluate initial certification.
Well, let me ask a quick little follow-up, and again, it's based off the Newspin article that we have in our December issue. I'm going to read a quote from their article, and it talks about the purpose of initial certification is to objectively and independently confirm that physicians who complete an emergency medicine residency demonstrate core knowledge, skills, and abilities needed to practice emergency medicine at the highest standards. But the problem is that ABEM has no evidence to show that it can make this determination. I think this is what they're talking about in response specifically to the oral boards, not the written boards. And so I was wondering, in your role as ABEM president, how would you respond to that accusation from people that have, staked their careers in being board certified physicians?
Sure. I think there's several things. One is, examinations are assessed differently than other things in medicine, where you have RCTs and was just considered the gold standard in terms of level of evidence. Typically, we can show correlation, but it's a lot more challenging to show causation. And there's a number of things. I mean, we've published any of a number of articles about certification, and there's several things. One is a risk of state medical board disciplinary action. We know that if you were once certified, you were initially certified as an emergency physician, and you let that lapse, you have 2.5 to 3 time risk or fold risk of state medical board disciplinary action. The other thing that we know that emergency physicians, in terms of dealing with patients with myocardial infarction, they not only can identify it and treat appropriately, but it decreases the risk of significant adverse events as well as costs if you're board certified. And so I think those things are really interesting. The other thing we looked at is kind of the robustness of our LLSAs in terms of not only relative to kind of impact the RCTs, but they were low risk of bias and had pretty significant impact as part of our lifelong learning and self-assessment. And then finally, one of the things, we really believe in non-complacency and continuing, to strive forward. And every year we try to make things better. ABEM submitted its certification program to an external review by the National Commission for Certifying Agencies, or the NCCA. And ABEM is the first medical specialty board to receive this NCCA accreditation. And it's the highest standard for testing and assessment organizations. And we're very proud of it. I mean, it took a lot of effort. You have to do job analysis, ongoing quality improvement activities, as well as you have to demonstrate that your certification exams have high reliability and validity. And so by getting that certification, we feel not only do we got it, but you have to maintain that over time. So this is a commitment we're making to all our constituents, including all the board certified emergency physicians in the United States.
Right, and I think that there's at least, 41,000 board certified EM physicians out there.
Yep.
But we know that there's way more than that numbers of physicians working in emergency departments, whether they are other specialties or maybe EM, as you said, that either let their board certification lapse, or maybe people that have never been board certified. But what would you tell the public about why they should want their doctors in the ER to be board certified?
Well, I think it's essentially it's considered the highest standards. As you saw at the ACEP Council this year, there are a number of resolutions kind of basically highlighting that the standard for emergency departments board certified, being board certified in emergency medicine. And it's an indicator for the public to know that the position has met rigorous standards for the credential. And I think that's critical. Not only do we have a public member, but we have multiple public members providing input on a Becoming Certified task force. And what's fascinating is what they say is that when they walk through those doors, they expect that their physician is going to be trained at the highest standard, and that includes board certification. I think one of the things we need to do is build additional awareness. We do know that the public cares about certification. They don't necessarily ask us directly, but through the ABMS Certification Matters website, they're checking hundreds and hundreds of times this year if their emergency physician is board certified. So we know that they care, and I think we could, frankly, I think we could do a much better job at educating the public around that, and I think that's something we're looking towards in the future.
Well, I think one thing that I've noticed, and I've always wondered, especially the past 2 years as COVID has gone along, is that we have a lot of doctors that are practicing in what I guess people would say emergency medicine, and you're not really sure, like, are they actually emergency medicine trained? Are they board certified? That sort of thing. And ABEM has started to tackle that issue of physicians that are speaking out against proven measures to tackle things like COVID. So maybe speaking out against masks or vaccines, or talking about unproven items such as like hydroxychloroquine or ivermectin. And can you tell us what ABEM might be doing in regards to those physicians?
Yeah, well, first of all, in April of 2021, we released a statement on professionalism. And then in August, we released a statement about misinformation. And we have a process in place that allows anyone really to report an emergency physician that they think is spreading disinformation about COVID, its treatment, the vaccine, etc. It's really important to understand that we have a thoughtful process for evaluating these cases. I've talked to any of a number of emergency physicians, and they had great things, that great concerns, and we talked about what the process was, and they felt a lot more comfortable at the end. And I think, just to be clear, all emergency physicians with whom there's a concern about professionalism has the opportunity to provide ABEM with information about what happened, and will be given due process and appeal options. And I think, this is challenging times because the information is dynamic, as you know, Cedric. I mean, I think it's one of those things. I felt like in my role as a medical director for LA County EMS, and being involved hugely in the disaster response, I felt like I was drinking information from a fire hose, right? I mean, it was coming so fast and furious, and we try to synthesize that information in a way that makes sense. And I think part of the challenge that we have as physicians is to try to explain the dynamic nature, that new information is coming all the time, which helps shape our thinking about various things. There's some things that are very clear. I think, vaccines work. We know that. Our hospitals are not filled by people with vaccine reactions. They're filled by people with COVID. And so I think it's important for us as physicians who are looked upon as authority figures and someone who can provide information and synthesize information to the public, that we take that responsibility very seriously. And so that's what we'll be doing. We'll be reviewing those, and we will allow physicians to talk to us about their thoughts, and we'll go forward with this. There would be an option for some type of disciplinary action if indeed it's found to be egregious in nature. And, I think the key thing is that we have a thoughtful process that reviews all the information at hand, and we also have a due process and appeal.
The physicians that are practicing and board certified are reading the primary literature, reading their copy of Annals, or reading JCEP Open on a routine basis? Or do you anticipate that they get their information from other types of sources?
Yeah. I think emergency physicians get their information from lots of sources, right? Some is synthesized, some are not, some are primary. I don't know. It's a great question. We should probably, and I'm sure there's data on this. And one way is to empower them with the knowledge and skills and reinforce those knowledge and skills such that they feel capable every day when they go to work. And I think part of our process is building a different type of relationship with emergency physicians, one in which we want to partner with them in this journey, in this career journey that we have. I mean, I've been practicing emergency medicine now over 30 years. I don't want to tell you exactly how many years, but it's definitely well over 30 years. And I can say that I've learned all along, every shift I say it's not a good shift unless I've learned something today. So as a board, right, what we want to do is we want to partner with our emergency medicine community to continue to provide them information in a way that will help them be better doctors.
That's great. I have that same philosophy as you, is what did I learn today while on shift? And a lot of times there's stuff I don't know, and I jot it down in a little note to look up a little later on so that I can continue to learn as I practice. One of the things right now, I work with residents, and one of the things I see is they love online resources, whether they're peer-reviewed materials, things like UpToDate. A lot of times people are looking at WikiEM. They might be looking at phone resources, and some of those you might find in the pages of ACEP now, like the Skeptic's Guide to Emergency Medicine or EM Cases. How has that transition informed what ABEM has been undertaking, and how does ABEM vet data sources when it comes to things like the MCert test? Are they using the more traditional resources, or are you also using some of those online and free open access medical education resources?
It's a great question. First of all, on our new advances panel, we have, a blogger, EM specialist, NACM edition, just to, really kind of leverage the best of what's happening right now in terms of transmission of information and synthesizing that information. So as an example with our concert, which is now going to be phased out, as you're aware, even before it became a take-home test, the people who were taking concert had access to UpToDate, as an example. And for all of our tests, including MyEMCert, they can look up anything at home. Let's face it, when you're in the ED, I look things up. I mean, I don't remember, to go up or down to do the lateral canthotomy. I mean, how many times have I done that in my career, So I think all of us do some just-in-time work. So our thought moving forward is, how can we leverage both traditional and non-traditional resources to allow and to provide our emergency physicians the opportunity to look things up as they go through this process, which I would like to say is a process. It's an examination. Let's face it. There has to be some kind of summative, a decision ultimately. But the bottom line is we give every physician every opportunity to use those resources that they have available to answer questions.
One thing that I noticed with MyEMCert coming online now is that the duration of the certification process has shortened from 10 years to 5 years. And why was that change made? And a secondary question is it going to shorten further in the future, perhaps even to that 2-year time frame? I'm used to having to renew my medical license, my state medical license every 2 years, my hospital credentials every 2 years. Are we going to get to the point where we're doing board certification every 2 years?
It's a great question. I think some time ago, as an organization, ABEM recognized that the ABMS standards for continuing certification would likely require that the period be shortened. And in fact, as we rolled out MyEMCert, we heard from, we did a survey of practicing emergency physicians, and within the first 2 weeks, 13,000 physicians had responded. And what we heard from them is they really don't want an every 10-year high stakes exam, right? And what they wanted is something like MyEMCert, which is an assessment for learning. So we had the opportunity with the transition from 10 to 5 to allow those in the 2021 cohort in which their certification would expire. We had the opportunity to be able to produce enough of the MyEMCert modules to allow them to certify by that process. And so because of the overwhelming interest in doing so, we thought instead of waiting, we should do it then to allow that cohort and the cohort after that, so 2021, 22, and so forth, to be able to utilize MyEMCert as part of their continuing certification process. And one of the things, given the rate of change in medicine, I think all the ABMS boards, as well as the public, recognize that something as important as certification needs to be more timely, current, and relevant to today's practice, right? Do you really want somebody to go 15 years before they have to show that they have knowledge and skills to continue practicing? And so I think, from a face validity, it was clear that we need to make the change, and we decided to make the change at a time that it would benefit most of our already certified emergency physician, and especially those cohorts right at the cusp of that change, to allow them to do something that they felt was not only a take home and they could do it on their own time, but something that was a lot more relevant. And in terms of going shorter, we haven't discussed that yet. And we have discussed some other innovations to try to assist emergency physicians in continuing to really have the knowledge and skills and resuscitation of patients of all ages. There's a lot going on with the board in order to continue to try to push the envelope, really with the goal of helping physicians be the best doctor they can be.
Let me ask a couple questions about the certification process and as you were saying, trying to make it more true to life. Because we always talk to our residents and our learners about, you're going to answer this question this way on the boards, but in real life, we practice this way, especially when it's that initial certification. How do you make sure that ABEM certification process comes closer to true daily EM practice?
Well, one way we do it is you can't be an item writer unless you're working in an emergency department, right? You don't want theoretical questions by individuals who are not practicing every day. So I think that's number one. And also, every question that we have on our exams requires support in either standard medical text, peer-reviewed journals, etc. And so, the bottom line is, if you're not seeing patients, you're not writing ABEM tests or module content. And I've already talked about our key advances panel, which is editors and evidence-based medicine experts, researchers, bloggers, to review all the information and synopses. So, and the other thing that we do is that every question has statistics related to it in terms of reliability, difficulty, okay? And so and so forth. And so we review those, and those that don't score well don't make it. And I think that's really important, right? The other thing we do is we do standard setting panels where we have individuals who are practicing emergency physicians from all over the country come together and help us determine the pass rate of these, and they also vet all the questions on the exam. So it's really a pretty rigorous process. And then finally, when you take these, any exam that we have, you have the opportunity as someone who's actually, in the middle of taking an exam or afterwards, comment on a question. And we read all those comments. I'm an editor for MyEMCert, and it's great. I love getting the feedback because it creates a dialogue, with our test takers, frankly, And then we look at that information and just make a decision based on their comments and what we know based on the literature. So anyway, it's a great process. When I first came on the board, I didn't really fully understand the ABEM process and what they do, and now I just am just blown away by the amount of rigor to make sure that those questions that get on the test. First, many of them are field tested. MyEMCert, it's a different process. But the bottom line is all of those are evaluated in some way to make them a better question over time.
All right, and this is the last thing I have to ask you. This one's a little bit about zebras, okay?
Yeah.
So, and this stems from the article that we have in December's issue of ACEP Now. Dr. Heather Studley, who's a physician that we interviewed about MyEMCert, liked the new test because it focused less on the extremely rare cases. Like for her written board, she had 5 questions on sarin nerve gas, right? And regarding MCERT, she says, and I'm going to quote, if you're trying to test me on the spectrum of what's relevant in my practice, it's definitely not sarin nerve gas. So how do you balance evaluating emergency physicians for the knowledge of common things versus being prepared for those uncommon occurrences?
Yeah, I think the issue is if it's an uncommon occurrence with high impact, that's something that you might test. Really rare complications of medications that we almost never use in emergency medicine is something we're not testing on. So overall, a common message that we're hearing from physicians is that they prefer MyEMCert format because the content is more relevant. And the goal here is to create scenarios that you're going to see, right? A 40-year-old woman with right upper quadrant pain and fever. And I'm sure, Cedric, in your head, you've already established a differential for that patient. And so that's the kind of we do common presentations, and then we help the physician work through those to reinforce knowledge. Keep your differential broad, then bring it in based on physical exam findings, laboratory values, and diagnostic studies. So I think we really are moving, as you can see in the MyEMCert, to be really timely, relevant, up to date for sure. And again, clinically active emergency physicians are developing these tests and modules. So I think that really helps. Not that they weren't before, but I think the issue is here. This is a different focus. This is, let's reinforce what we know, and then let's also push us a little bit to continue to really make the specialty even better than it is. I mean, that's our goal, right? Is to make things better over time.
Well, thank you again very much, Dr. Marianne Gausche-Hill, for joining us today. And thank you all for listening to us right here on ACEP's YouTube channel. You can also listen to us on ACEP Nowcast, which is our podcast, or you can read us either online, acepnow.com, or in your own mailbox when ACEP Now hits your pages. So thank you very much, and I hope you have a great day.
Thanks so much for having me. It's really great. Thanks, Cedric.